really, when I'm going to teach you next, we're going to work on thoracics. I can teach you T4 or I can teach you T12. There's no difference on the way to adjust it other than line of drive. Well, you guys have got to know your facet lines, and we'll talk about it, but that's really, we don't have time to teach you facet lines and line of drives all day long. This is your homework. But what we are going to teach you is hand placement, and I think the biggest thing you guys got to learn is once you find where this bone is, once you decide that's where it is, that's the bone that needs to move, what we've got to get through to you is move the damn thing. Move it. I promise you. They used to take a table, and you can imagine two pieces and there was nothing in the middle. So they're laying there with their stomachs like this, 100-pound sack of flour on their shoulders, and drop all the way through till their stomach hit the ground. That's how they adjusted. They did it for years. And you're worried about hurting somebody on this table. You've got to learn to adjust. You've got to get in there. And me and Tim will say this. You'll hear us say, okay, now do what you just did times 100. You're going to hear this, especially my girls. And I get it. It's just different. But you girls, here's the thing. You're no longer girls. You're chiropractors. Different breed of animal. You guys don't think the same. You don't act the same. You don't do the same. You have a different purpose. So when we go to set these things up, I don't want you guys hesitant or I mean set up, decide what you're going to do, and I want that thing moved. It's just going to speed your learning curve, okay? Any questions before we get started? Primary subluxation?
How few segments you adjust?
Okay. And it's actually, yeah, because you guys really need to hear this, because it's, especially even doctors, I mean, this is really important. I mean, you guys that know me, you know, you understand, you know, how we do things. 27 vertebrae, okay? And you got to look at, good Lord, what people do. They're going to come in your office with everything. Now, they may have been skiing 2 weeks ago and had a wipeout and now they hurt, or you may have somebody that in 1966 got run over by a taxi cab in New York. I just had that guy. It was the longest consultation in history. I mean, this old man, he was 80 years old, and he was telling me when 1966 was the first time he got hit by a car. 1968, he got hit by another car. I'm thinking, you need to stay off the sidewalks. I don't know. But again, you're going to have a spine come in, and it's going to be riddled with arthritis and degeneration and bad disc and bone spurs and all this stuff. And what are you going to do? Try to break up all of that? So what you have to do is there is a primary subluxation in this body. And typically, 1 to 2 is the most. Now you may have 3. I don't think there's anything wrong with adjusting compensations, putting motion in it. I think that helps facilitate healing and correction. But our focus is on the primary subluxation. Again, what I said earlier is if you have somebody that, you know, falls or injures himself and they hit T12 and it rotates, and I'm over exaggerating for purposes, but it rotates. Well, when it rotates that way, the body's going to turn this way to get away from it. Because if anybody here ever have a pinched nerve, or anywhere, you know, or a bad back or a rib out, do you lean into it or do you lean away from it? Watch people. You ever watch when they stop? Why do they do it that way instead of this way? Well, they're taking pressure off what? Over here, right? And when they stand up, do they stand into it or are they going to stand over this way? But they're not going to come in your office looking at you like this. They're going to be here. So the body will compensate for the subluxation. Treat the subluxation. Now, how do you determine, oh, I'm glad I started all over again because someone asked me this. Asked me about x-rays. I'm not going to say, I will not say that the schools are crazy by telling you don't x-ray, they're dangerous. I'm going to say x-ray everybody. Every damn buddy. Unless they're like an infant or a child, and there's no, they're just coming like for a wellness treatment. I x-ray everybody, and we have digital, so it's real quick, it's real fast, and real effective. But I'm telling you right now, I diagnose subluxations from x-ray first. Now, well, I say first, actually second. First, they're going to come in and say, I hurt right here. My neck hurts right here, and I can't turn my neck. Well, where do you think it's at? Probably it's right there, more than likely. But patient comes in a month ago, who here are going to focus? Every hand better get up. I'll talk to you about it later. He's actually going to speak at Focus. He wants to tell a story. He's trying to get on Oprah and tell a story. Patient completely lost his voice. Could not speak. Not a cold, not the flu, not laryngitis, no voice at all. He goes to all the specialists, CAT scans, MRIs, blah, 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 blah. They've determined that his vocal cords are paralyzed and they need to do emergency surgery. They're going to cut some flaps, sew them to his vocal cords, try to get new nerves. They're going to do all this crazy. And you'll hear him tell his own story. Of course, he doesn't want to have his throat cut on, and his job requires him to speak. So this is like life-changing here. I mean, think about if you couldn't speak, or just think about if you couldn't open and close your hands, being chiropractors. Wouldn't you panic? Okay, something's not right here. And they're going to do this crazy-ass surgery that probably won't work. He gets online, like what everybody does now. They start Googling this, and it goes nerve, and then all of a sudden chiropractic come up. Well, I don't know anything about it, but I'll ask, and someone referred him to my office. When he come in, he could just barely whisper. You could hear air coming out, but you could read his lips enough to understand what he was saying. Kind of figured out what was going on. I took an X-ray, lateral cervical X-ray. There it is, C5. Doctors, and I've probably already told you guys this before. Look at all your lateral cervicals, and you look at the number one most degenerated bone in the body. What is it? C5. And I'll get into that a little bit later when we get into cervicals. I'll go into that a little bit more. So what did I do? I adjusted C5, and that was it. And when I adjusted it, I wasn't playing patty cake with his ass. We moved that bone. 3 adjustments, he's talking just like I am. Now, did I quit adjusting him just because his voice came back? Let me ask you kids this. Was I treating his voice? What was I doing? That's what I like to hear. His subluxation wasn't corrected yet. He had degeneration in that bone. I was going to correct it. Every time, now he come in on his like 6th or 8th visit, and he goes, all my coworkers are wanting me to, they're trying to get us on Oprah. This is a miracle. And I'm just kind of smiling. I said, well, chiropractic is a miracle. You don't get it. Here's what happened. He explained chiropractic to me better than I promise you most of your professors can. Most chiropractors can. He had it down. I just looked at it and went, okay, would you like to say that again on stage? He said, I would love to. So, but my point with all that being is, I took an X-ray. He told me he couldn't speak. Well, if you know your neurology, 5th cervical, the nerve bundle, what's that do? Voice box, vocal cords. Then you take an X-ray, well, damn it, there it is. Look at the degeneration. Look at the misalignment in that spine. So what do I adjust? That bone. He lays on his back. I set that bone. He sets up. He's in and out of my office in 15 seconds. Do you think he cares that it's 15 seconds? Matter of fact, is it better at 15 seconds or 5 minutes? Same result. If you read your green books, and I know you guys aren't taught to, BJ said you spend more than a minute with them, you're stealing their time. And that was in 1919 when he said that. So, don't get me on my philosophy. Back to this. Primary subluxations. What we're going to do is I'm going to have, kind of spread your tables out a little bit. I'm going to have patient laying face down. I want everybody else. And what we're going to do, all I want you guys to do is start up here, supple fingers. Like Tim said, not heavy hands. You start jamming your fingers in someone's spine, they're going to tighten and they're going to think 2 things. They already hurt me, I'm already scared, and they don't know what the hell they're doing. I want you just to palpate down through, and then whenever you found the vertebra that you want to adjust, I want you to raise your hand, okay? When I walk over, or Tim walks over, either one, all I want you to do is set up on it, and I want that bone moved, okay? Now, keep in mind, students, remember this, and you guys need to know this, but just for classroom stuff. You have 3 curves, right? Lumbar, thoracic, cervical curve. We're working on a thoracic and lumbars. We got a thoracic kyphosis and a lordosis. So the curve here and here. So you've got to grab the spine. This is why, you guys get your spines out. If you have to lay it on top of your patient and look at the facet, then that's what we're going to do. But what's going to happen is once you find it, I'm not even going to check it. You find it, you set up on it, and when you're ready, I want that bone adjusted from there. Because this class is about moving the damn bone. In time, you get better and more specific and all those things. But right now, you guys got to feel that. Like Tim said, that transformational moment, we saw it in Denver. I'll never forget a little girl, she was scared to death to adjust. And when she got that first cervical adjustment, I mean, that bone moved and we heard it across the room. Her eyes got this big, and I think for just a minute she thought she broke him. She just started bawling because she did it. And I promise you that will change her life. So that's what it's about, getting in her movement. And guys, even the ones that we've been in practice for a while, it's about adjusting, getting in, getting out, and getting the hell out of the way. Okay? And that's what I want you students to learn right now too. So let's start on that. We're going to get some, yeah. Okay. Now look, we're going to use these pillows for an example. So when you first start out, if you was to take this and put this over the top of it, that's how you guys are palpating, trying to find it through this paper. I mean, I remember, I will never forget our first palpation class. We all got paired up, and I got with the biggest girl in class. Like, are you kidding me? She had that much tissue between her back of skin down to her spine. Now, I can palpate every one of those spinuses. Okay, that's just years. So what you've got to do is when you palpate, you find it, but then when you set up on it, over the top, I adjust on this side. So when we're over the top, find your area. You're not adjusting from out here, on your toes, and we're adjusting. It's not that. Okay? Come here, big boy. Face down. Everybody come up here so you can see, and then we'll pair off. Okay, and the first thing I want you guys to do is look. What do you see? What do you see? What do you see right here? See the difference? Okay, so the body's telling you exactly where we're going to look first, right? So if we're going to concentrate on thoracics, I mean, I can tell you right there, all right? A little trick that I've always, and I just taught myself to do this, and I had to deconstruct this. If I get, especially a new patient, I'll come in and I'll just slightly squeeze the trap here and here. One side is going to be tighter than the other. That's just a neurological response to protection. The body's always trying to guard an injury. So he's got more on the right side, which comes here. So the first thing I'm doing is I'm looking here. I just have to address this because I'll forget if I don't. Ribs do subluxate. I don't know if you've all, I have a feeling that some of you might have heard in school that they don't. Yes, they do. I'm just going to leave it at that. So what we're going to do is we're going to find, now again, you guys, I want you getting in here, and what you're doing is you're going to feel the muscle. Right now you ain't going to feel hardly anything. You're just going to think, well, there's a back there. But I want you just to let your fingers start learning. It's like Braille. Reggie Gold used to call it vertebrae. Okay, so right here, now I thought it would be a little higher, but it's actually right about there. Little trick. Take your hand, come up under the scapula, okay, where it stops. Thumb straight over, that's T7. Okay, so it's a really quick landmine. So if I tell you to go to T11, you don't have to start at T1 and count the spices. 7, 8, 9, 10, 11. So we're at 11, all right? Now, lumbar curve, kyphosis, right? So I adjust superior hand on the right, inferior hand on the superior hand left, no, right and left, okay, good Lord. Tissue pull is here, stabilizing here. It's on the right. I'm adjusting here. This is a stabilizing hand, but I'm going, look at the spine, the way the facets are this direction, okay? Now, you can get it to move straight down if you jam it hard enough. That's not really an adjustment, that's more of a manipulation. We want to adjust through the segment, right? So I'm going to come in here, and I'll show you, we'll go hand placements and all that. I just want to show you something. So when I get on the top of it, I'm over the top, I'm on my toes. Okay, I'm on my toes. You can do this if you want to. I think it's a waste of damn time. You know, take a deep breath in, let it out, blah, blah, blah. Patients, if you do that, if you say take a deep breath in and let it out, when you say let it out, they know you're going to adjust. So I don't tell him when I'm going to adjust. It's my job. And I set it. Okay, you see his feet kind of come up? All right. Now, when I made that adjustment, it moved a little. Okay, so which means to me, just through experience, that that was a compensation. That wasn't the one I wanted. Again, so I'll come back up. That's the one I wanted. Okay. Any questions about what I did before we get started?
Justin?
Yes. On this I use this hand away from me as the side I'm adjusting. This is the side I'm going to adjust. Well, you know what? No. I just use this, when I'm on the left side of the table, my superior hand, which would be the left hand, is always on the right side of the patient. My right hand, inferior hand, is always on the left side of the patient. If the vertebra was on this side, I'm using this hand to adjust.
So you just always adjust from that side?
I do. I always adjust. Now, well, 98% of the time. There are times in the lumbars that I will go around to the other side, and when we get into the lumbars, because that's a whole different animal, I'll bring that back up. Don't let me forget why I go the other side. But here's the thing. If you're going back and forth, that's the steps, wasting time. And here's the thing. You guys are all going to be high-volume doctors. You will hear doctors, you will hear people out there that will use that like that's a bad thing. Here's the thing. You have to be high volume because you're the only ones that know what the hell you're doing. So everyone else, when they're seeing their 5 and 10 a week because they don't know what they're doing, everybody else in the world needs a good chiropractor. They're going to come to you. Well, you better be high volume because you won't be able to handle them if you don't. Does that make sense? So the high volume, all that means is I'm seeing everybody you can't. That's how I look at it. Contact points are the transverse processes. And the spinous is in the middle of your hand. So what I'll do is I'll come off the spinous process. So the spinous is here. My palm, or I forgot all my anatomy, hyperthenar, will come in here and I'm just kind of taking it, and you don't have to do you just don't have to. Just get your hand in here. Now, let your hand go kind of flat. Don't have it up in here because, that opposed to that is huge. And you'll see. So just get it in there, comfortable. Bring this in over here so you're taking the tissue pull. See look at his shirt. Watch his shirt. See that? Over the top. And then my line of drive here. But it's not this. It's not that. It's straight through. Okay? And that's why I grabbed him. He's not going to be like this guy. And you got, as chiropractors, you're going to have a guy like him, 6'8", 365 pounds is going to lay on your table. And the very next patient is going to be a 98-year-old woman. The next patient is going to be a 6-week-old baby. What are you going to be? Okay. Any more questions? Nope. All right. Let's pair up. Find it, raise your hand, and get ready to adjust it. I'll show you all that again. The difference, okay? And I get to pick on Josh. But see, if you're doing that, okay, that's what happens. But if you get in there and you set it, that force, you have more symmetrical, or I don't know, it's just more energy into the joint. Does that make sense? Keep your elbows locked. Keep your elbows locked, drop through. Okay? That way you don't hurt yourself.
After you adjust it, it will continue it.
Exactly. Yes, she made it perfect. She read my mind. Let the momentum of your adjustment continue even after you've made the adjustment. Let it follow through. Perfect. Okay. I'll show you that. Hey guys, real quick, I know I keep interrupting you, but this is really important. When you get down here, we've been kind of working, I've been kind of keeping you guys up in these upper thoracics because that's real easier to adjust. And you get down here around L1, T12, T11, always, and this is us guys have been in practice a while, man, right here, back it off. Because that kidneys are right there, and the body has a way of adapting and protecting itself. And when you start getting around here, you're going to watch them tighten. I mean, the butt cheeks are going to clench, and I mean, they don't want to be messed with right there. It is the most delicate. I've had chiropractors slam me there, and it's like I just want to beat the hell out of them. It's like, what are you doing? So when you get down here, this is just the way you do this. Even when you guys are in clinic, or where's my students? When you're clinic, or it doesn't matter who it is. I don't care if they're a great big guy. You get down here and let's say it's T12, okay? I want gentle, very gentle. Now what you were asking me is the line of drive. So we have the curve here, so we're gonna go about this way, okay? If you look at your facet, you see how that sits. But it's gonna be, see how I'm getting down in here into it? But I'm gonna come down and up into it, not straight down. That spine will bounce and it'll guard, and that's the quickest way for a patient never to come back, is when you hurt them here, because there's nothing like that. So what I'm doing is I'm just kind of taking the tissue, but I'm kind of coming up the spine, real gentle here, and rock into it and feel. And what you guys have got to do is you got to let your hands be your eyes. Learn to see with your hands, and just you take it. You don't have the patient take a deep breath. You take a damn deep breath, and just let it go and feel what's happening in here. Get your body right. If it ain't right, change it. And when you know it's right, you'll know. And once she relaxes, real gentle, and right here, do not drop through this one. It's a real gentle right there, and it just adjusted perfectly. Okay. The key to this is you relax, and you keep them relaxed. Because I promise you, in this area, if it doesn't adjust, they're going to walk away and come back for the next adjustment. If you force that one, they'll walk away and tell everybody that you're an idiot. I mean, they just will. They'll never come back. You got to be careful right here. That is so vital. So, and you'll see quite a few T12s, because T12 is a transitional segment between the lumbars and the thoracics. So you'll see that a lot. You'll see these. I hate to say this because it sounds like a cookie, but typically, unless there's something going on, I check 3 areas: C5, T5, T12, 4 areas, or L5, S1. I mean, I look at those areas, probably the most subluxated areas that I see. So, I mean, again, I hate to say this, but it's just true. It's just the way practice is. If you was to adjust C5, T5, T12, and L5, and pick those bones, you'd have a great practice. Now, don't do that, because that's not being a proficient. That's not being an artist in what you do. But I'm just saying, in all else fails, go there. But on that area, man, just take your time on that. Okay, and then you guys, and then adjust. Okay, all right. Has everybody been adjusted and everybody adjusted? Everybody? You haven't been adjusted yet? Or you haven't adjusted? Well, get after it. Let's go.
We've gone over it in the past, but the turning of the head or even raising of the head
Mm-hmm.
to almost block that diaphragm at the T12, does that make?
It doesn't to me.
To you, okay.
It doesn't to me. What Josh is asking, there are different techniques, and I will tell you there are times in upper thoracics, if I have a real tough time, I will have them turn, if they're right-handed, to the right, left-handed to the left. The only explanation I have of that is I've done it in the past and it worked. I mean, seriously. But as far as down here, I don't have them do that. But if you feel comfortable with that, sometimes it's just a matter of the patient's guarding, and you change and you get them to think about something else for a split second. And when I get into cervicals later on this afternoon, we'll really get into a lot of that. But they're like what Josh is saying, before he makes an adjustment, he'll have to take your head and turn it to the right, and then he'll set it. Now, or lift, or just do different things. That's personal preference. Again, go ahead and sit up. What's really, really important, you guys, is after practicing for a while, it's interesting. Going on almost 20 years and hundreds and thousands of adjustments, I learn every week. I learn something new, not only about chiropractic, but about myself. And the key to being a great chiropractor is trying to be a great person first. You improve yourself every day. Every time I make an adjustment, I want it better than the one before. Now, I'm not saying that happened. That's what I want. The majority of the profession is like the majority of the world. 10% of the world makes 90% of the money. Facts. 10% of the world pays 90% of the taxes. 10% of the chiropractors see 90% of the patients. You just got to decide which you want to be, the 10 or the 90%. And to be in the 10%, it is trying to improve yourself every single day, not just going through the damn motions. You don't work at McDonald's making hamburgers. You are changing lives. Okay, does that make sense? All right, any questions about thoracics?
Can you set up a line of drive for T1, T2?
Yeah, that's what we're getting around. You just led us right into it. All right. Let's do this. Now, we're going to change it. What we were working on was middle to lower thoracics. T1 through T4 is a whole different animal. So, come on. Now, I don't like, whose table is this? How's this thing work? There we go, just down a little bit. When I'm adjusting upper thoracics, I like the head either neutral or down. I don't like it back at all. Now, T1 through T4 is probably one of the toughest areas to adjust in the spine, mainly because your lats, your delts, your rhomboids, your traps, your erector spinae, everything is right there. And I always look at T1 like a big tent, like the center tent pole, holding it all up right there. It's a transition. That's why it sticks out so far. Probably the biggest spinous process in the body. It's just a bear. And I've personally went through the experience when that thing subluxates, it'll shut you down. There's different ways of adjusting it, and you'll learn a ton of different ways. I have to try to show you guys, like the students, how to get this area to move to where you'll learn from there. The way I do it is years of practice, and I'll show you guys that too, so you have something to work towards. And then my doctors in the field, I want you guys to practice it even more. So let's go. It's basically the same thing, except for the fact that there's so much more muscles behind it, or around it. There's not as much here, in between. The line of drive is different because of the kyphotic curve. The amount of rotation and motion in the joint is less. So let's go. We'll just start with T1s, which is the hardest. Now there's different ways, and Tim and I went through these several different times. I'm gonna eliminate a lot. I think Tim and I went through lots of different adjustments in the last several classes. It's good for you guys to see, but it's like a bit overwhelming. I'm gonna start honing it down and shaving off all the. We could both teach you 20 different techniques on moving these bones. I don't think it serves you well. I'm going to show you one or two that you just need to practice on. A black belt knows 1,000 different moves, but he only uses one or two. I mean, it's just all he needs. So now, depending on the table, and this is a big thing too, you need a good table. There's what we call the prone adjustment, and every now and then I'll get it to move. And if you look, give me a spine. Give me a spine. Thank you, honey. If you look at the spine, okay, and you look at the T1, look at the facet, see how it's like right here. So it goes about that direction. So you can't adjust it that way because all you're doing is jamming the facet, right? You got to adjust it through the facet. So if I was to get if I was to get my fingers right here, spinous process between them, or like where I'm strong, and adjust this way here, because it's going to subluxate depending on which way it subluxates. But if I can get it to move here, then I will do that. And sometimes I have some patients that's the only way they move. I've tried everything else and nothing. I'll get in there and set it. I'll be damned. But let's say it's subluxated to the right, T1 to the right. Now you can come in here, and I'm not going to adjust him this way because I want to show you something. I'll take my thumb, spinous process here. Okay, can everybody see this? Come over here, Sissy. I want you guys to make sure you see this. Spinous, so my thumb's against the spinous, okay? This hand is coming down, and what I'm doing is I'm picturing, I keep throwing that down, I need to leave it up there. So, spinous, and then this part of my hand is here. So I'm moving this whole bone from here back over here, okay? So the spinous is here and it's here. Now I'm not jamming the spinous because that hurts. There's nothing in there. If you've had anybody just jam their thumb in, I'm adjusting through the body, So this transverse process, is that right? Yeah, is in between my fingers. And so this part of my hand is down here over the body. So I'm using the whole vertebra to adjust, not just the spinous. It's kind of like the seated chair move. You come in here and you bend the head over it and then you drive through, okay? And we'll work on it. So I'm going to show you 3 different moves. That one, I'll show you 4 different moves. here's what I don't like about this adjustment. It works. I don't like this. Those shoulders on us are going to go south.
Yeah, I was wondering if it's easier to do it from this side.
I'm getting ready to go to that one. Yeah. I will do this sometimes. The only time I do this one is if it's a kind of a big patient that's real tough to adjust. I mean, he's got like all of this, and that thing's not moving, and I'll have to. And I mean, I'll get in there, and when I set it, I don't want it on tape because it's violent. I mean, I'm moving it. Now you can come. Now I'll just do this side. So instead of going across, let's say it's on the left, instead of going over here and doing that, you can get in here. Don't do this. Get that arm in here tight. Same thing. Come across and through here. Okay? So you can do the same thing. I like this better. To be honest with you too, if I'm going to do this, instead of walking around, I just do it that way because I don't want to walk around. I just want to take the time to do it. So we have this one. You get the prone. Students, don't worry about prone. Doctors, we work. Don't worry about the prone right now because everybody's going to have different tables. You're going to be portable. You're going to start jamming each other's face into the poles, and everybody's going to be mad at each other. Don't you do that. Work on this one or close. I prefer this one with you guys. I think you have more control with it, and you're not going to hurt yourself. The one I personally like, over on your back. I like this better because I feel like I have more control. But the only hard part about this is you've got to have hand speed. You won't do this with it unless your hands are fast. If you got slow hands, all you're going to do is jam it. But so the same principle as the seat as the chair, but I'm going to come down the T1, and I'm coming. And now you got to picture for the set. I'm not jamming into the facet. I'm going to come up through the facet, right? Okay. So I'll show you on him what it looks like.
I've got one.
You got one? Okay. Let me check something here. Okay. He's got one on the left. Okay, lay back on your stomach. Let me ask you guys, I'm going to ask you, if this is your guys' class, you paid for it, does it help left, say over on your back? So, doctors, this is why you guys came. Okay, this isn't, I know it helps to break things down, but students, I want you to just listen to this for a second. Someone comes in your office, you did your x-rays, you did your analysis. Back on your stomach one more time. So they walk in your door, screen, you see your segments. So let's say on your deal you have a T12, T1, C5. I'm gonna make it shit up, but so let's do that, okay? So he comes in, face down, T12, okay? Adjust it. Over on your back. All the way up. Have a great afternoon. I'll see you tomorrow. That's what we do. Now, I didn't say, how did that feel? Do you feel better? How's the puppies? What did I say? Have a great afternoon. I'll see you tomorrow. That means I'm done. But did you guys notice I adjusted it, lay it on your back again. I'll deconstruct it, but I wanted you to see how I would do it in the office. My table's about that much higher, so I get to stand. But I'm getting in here and I'm setting the bone. I'm not jacking around with it. I know it's T1. T1's there. Bam. I set it. And then if you had a cervical, I want to save the cervicals for this afternoon. Then I'd set it and then up. I do this always. If they're on their back, when I'm done, I help them up. There's two reasons for that. One, to help them up. Two, to get them the hell out. Because they'll just lay there and have a seat. And there's even patients that will, it's typically my older female patients, they'll just do. I'm going to find a primary subluxation, and I may find a secondary or a compensation that I'm going to take the restriction out of it to allow more motion, increase the speed of healing, whatever you want to tell yourself. But I'm going to find the primary subluxation. Once I find it, I'm going to list it somewhere so when they come in I can see it, because at 200 to 300 a day, you don't eventually you kind of do, but you don't remember everybody. And you want at a glance, C5, 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 see you tomorrow. That's how you do it. Tyler.
You're looking at your x-rays and you see, T1 to the right and T12 to the left.
Is there a way to say that's primary, that's not?
I will go, well, and I'll get into this afternoon, but I'll go to C5. And I won't even touch those because those are, both of them are compensating. There's another primary, and I'll explain why I think that and where I got it and why I got it and why it's working. So remind me this afternoon. Does that make sense? Okay, we need everybody. Do we want to work on adjusting these real quick? All right. Again, X-ray, 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 X-ray. X-rays are not dangerous. Good Lord, they were taking X-rays back in 1919 in the Palmer School, and that's back when they were going like for 15, 20-second exposures. Now we have split-second exposures with. It's just ridiculous. I don't know where this comes from, but X-ray. So we got 5 lumbars. The one you're going to see subluxated the majority of the time is L5S1. Doctors, do you agree?
Yep.
Almost always. You're going to see the sacrum more on the females for various reasons. High heels, gymnastics, cheerleading, everything is this. Having babies, the sacrum comes back, the hips spread to allow for the baby. You're going to see a lot of sacral L5, S1 subluxations. And typically it's posterior sacrum. But for classroom sake, what we're going to do is we're going to focus. If you can adjust L3, L2, L1 the same as you do thoracics. Again, be very, very careful. It's down here. When I do lumbars, I will take lots of tissue pull, get it all out of the way, get down to it, and you got to memorize. Look at your facets, because here's what's interesting about the lumbar facets. They actually sit like this, so you would think P to A would be easier to adjust, and it actually is, as long as you get your hand placement right. So I'll get in here. So L3, L2, L1, unless they're really guarded and spasm, that's how I adjust them. For classroom sake, I'm going to teach you guys 5th lumbar, L5, S1, okay, because that's what you're going to see the most. There's different ways of doing it, but no one is teaching you guys proper side posture at all. It's awful what they're teaching you. So let's go in here, and I'm going to find L5, and luckily I don't have to go on the other side of the table. Okay, so she's got a 5th lumbar on the left, okay? So now you're going to have, and I will tell you that most of the men that I adjust now, it's prone, it's here, and I adjust straight through. Females, I don't do as much because the sacral base angle, it's just not as effective, and I think it hurts them more. So what you do, and watch how I do this every little bit. They're going to lay face down, palpate. Okay, you're not digging, you're palpating. Okay, when I tell her, okay, I want you to lay on this side, turn and face me. Keep your hand on them at all times. Never take your hands off your patient ever. Okay, always keep your hands on them. I don't care if it's their first visit or 500th visit. I'm always got them. Now, these are the most important. Where's the lay shot? Sissy, lay this over there by my stuff, please. It's bugging me. I don't ever have anything on me when I adjust. Okay, so what you're going to do is gently turn off the shoulder. You're going to have people tell you on the shoulder. No, off the shoulder, just like this. Okay, and just relax. Now, I like to do this. The bottom hand comes up on the elbow. Do not put your hand on their shoulder. We're not jacking their shoulders out of place. This hand, just stabilizing, okay? Relax. And a lot of times they're nervous, and I'll just, okay? All right. Now, I'm going to have them straighten the bottom leg, bring the top one up, okay? Just like this. New patients, when they first come in, when you're first going to adjust somebody, sis, the hardest part about this is you're going to feel like you're falling off here. I got you. I've never dropped anybody, okay? All right. Reassure, like Tim said, touch. Here's the thing. Your shirt says it all. It says it all. It's one of my favorite sayings ever. But you don't say it. You are it. You love these people. I mean, I care about you guys like you're my own family, and I just met you. That's how I am. My patients come in, they will tell you, we're family. And when they first come in, they got to know, I got you. You belong to me now. Okay, so what we're going to do is, we're bringing a knee up here, and everybody's built different, and you're going to have different physiques and different blah, 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 but for classroom. So now, once I got my patient in this position, they're coming all the way off the table. all the way over. Feel like you're falling, don't you? Okay. See how my knee goes to the bend of her knee. Okay. I'm not digging. It just goes there. But what I'm doing is I'm stabilizing here. This knee comes up. But everybody come over here first for a second. I want you all to see this. So as they come over, this knee is close, so she can't fall because I've got her. This thigh goes against this thigh, okay? So here, everything is here. I've got her here. I'm not shoving. I'm just hanging on. So I've got her right here. It's impossible for her to fall off this table. I have her, okay? My thigh is right here. Now here's the secret. Now you guys can come back over here. What we're adjusting is the 5th lumbar on the left, right? Left, right? Okay. So here's the 5th lumbar. What most people teach you is shoulder, and you crawl up on top of them, and you're doing this thing, right? That's what you guys normally see, what you all seen and been taught? Okay. The number one reason chiropractors retire because they blow their shoulders. They used to call this the $1 million roll. You can make $1 million doing it, or you can get sued $1 million for doing it wrong. We don't call this a $1 million roll. That's manipulation. We call this a specific 5th lumbar adjustment, right? So L5 on the left. Pisiform contact. I'm coming in here, not out here. I'm focused on this bone. Here, right there. I'm coming in on the lateral process, or the lateral mass, the 5th lumbar. I picture the set in my mind. I'm tractioning my body as this kind of, my thigh to thigh contact. I'm kind of putting some weight into it. So I'm tractioning it. I'm not killing her here. Now watch. That's all there is to it. Now, I didn't go real hard and she didn't move real good right there because she's kind of guarded because I've been doing this for 15 minutes. But I'm going to let her rest a second. You okay?
Yes.
Yeah, it's kind of hard to do. I'll go in real time here in a second. But the main thing I want you guys to see is positioning on the lumbars is vital. Now, you're going to have some guys that are huge. The girls, this is Molly. This is something, and I think I tried to show you this years ago maybe when she came and helped me, I'm all gimped up. Girls, this is going to be really important for you. You're going to have somebody come in his size, okay? You're not getting them like this. It ain't happening. And I got them come in. So I will, it's not as specific, but I will come in like this, use my arm to come right across the top. You adjusted, you weren't supposed to. But that's all it takes, is just that little bit of a roll, and you get the lumbars to move. Sometimes, I will say this, in the lumbars, I would rather you get a little bit of manipulation and get movement in the lumbars than to not get anything in the lumbars. Tim?
For the remaining time before lunch.
I'll show you guys. I'm going to show it to you in real time. Face down. In real time. So patient comes in, they're laying face down. Now, here's something, I have to slow it down. Okay, when you just look at him, what do you see? What do you guys see right off the bat? Huh? See how much higher this is? See, it's higher than the other side. You guys see that? It's pretty obvious. When you look at it, it's sticking up. So you would think that the whole spine went this way, right? Because the bone's pushing the tissue up. And see, I already know without having to do anything that it's going to be about the 4th lumbar. Now, I can adjust it this way, but I want to show you guys this. So I'm going to adjust 4th lumbar, but I don't use my elbow, I'll use my forearm. Okay? I want to show you this. So I'm going to have you lay on your side, turn and face me. Again, never take your hand off your patient. Okay? See this arm? Pull them off. Always hang on. Switch arms. Straighten this leg. Straighten this leg. Okay? Okay, get positioning first. Now, when you got somebody big like this, you got to keep control, but you're not going to be able to keep them there very long, especially my girls. So I just take my thumb, just kind of put it in here, and as you come over, get in here with it. Okay, this left leg goes to here, right leg goes to here, and then I'm going to come right to that 4th lumbar. Okay, so I want to show you guys this. Ready? Right there, and then all the way up. Come all the way up. Just like that, okay? All right. No, it didn't hurt the shoulder. I used my body and set it. And a big guy, piece of cake. You could have done the exact same thing It's just going to take practice to get that. Okay? I keep everything tight and close to you. I'm going to show you one more thing, and I'm going to let you guys set up on it. You, face down. It'll be easier to show on. Now, as you get going, the reason I'm showing this because I want you to get specific. Find the bone, move that bone, move it right now. That's what we want to do. Now, again, look. Which side do you see? Right side. Yep. See how higher it is on that side? Look at the tissue. See how it's sticking out? See the body. The body is just it's just a roadmap. It'll tell you. So I see right there, fifth lumbar. Okay. So I'm gonna show you. We got to get in our heads. I want to move the fifth lumbar. Nothing else. Lay on this side. Turn and face me. Okay. Rest your head for me. Hand on your elbow. Bring this one up. Okay, we're going to the fifth lumbar, right? Now, I want you guys to see this, and I'm going to let you do it. I'm coming in on the fifth lumbar, and when I adjust it, I'm going up and through the facet. Right there. And then all the way up. Okay? Tight and set it. I didn't baby him. Set the bone. In my mind, I'm opening that joint up and putting that bone back where it belongs. Okay? But everything's tight, close, and fast. You ain't going to do it today. I want you guys to get setups and placements and motion. Okay? All right, everybody set up. Sets. There are times, though, if I want to open the disc, though, if it's like, if you want to open it, I will come through here, get my hand on it, traction it up, and when I adjust, I'm taking the whole spine and going right to the head. And I'm coming straight up the spine. Wham, up through there. So and when you were asking Sis about the placing of the leg, I try to just do it like right there. Just relaxed. Traction. Everybody, you guys are being taught this. No one wants to be laid on, and you have no leverage. Look at this. See, it's right there now. So then all I have to do is that, and it adjusts. You tired of being here? Yes, it's my palm crane. Questions about lumbars? How much time do we got, Doc?
About 10 minutes.
Okay, I'm going to show, since we got about 10 minutes, let's use, maybe that table would probably be better. I'm going to show you guys it's just the way they're made. So what I'm going to do is, and Josh is big and thick, so this is perfect. So he's got a pretty high lordosis in here. So he's got a fifth lumbar on the left. Okay, so, and I told you there are times that I'll go around. Sometimes if it was on the right, I would go around and do it this way. So instead of on the side, okay, and we look at the facets. Somebody grab me a spine. Okay, so look at here we go. So here, all right, so we're going to adjust. He's got a fifth lumbar over here. So here's the facet. So I want to adjust. I want this moving. Here's something I want you guys to think about. This is what I picture in my mind. We have a subluxation. What's happened is the joint has been injured and it's restricted. The joint doesn't move. So what happens is when the joint doesn't move, instead of motion, it's stress. Increased stress in a joint will cause swelling and inflammation, and over a long period of time, that's what causes the nerve pressure and all that, right? So what we're actually doing is we're introducing motion back into a restricted joint, and that motion will allow the stress to reduce and then allow the body to heal itself. Has anyone here had a broken arm in a cast or a broken bone in a cast? Okay, when you take the cast off, what's that arm or leg, what's it look like? It's atrophy because there's no motion, right? But as soon as you start moving it within a few weeks, what happens? It comes back. Motion is life, right? So we're putting motion in there. But so we look at the facet lines. Look how they sit. Now see up here, they're flat, but down here they are, right? So I want this joint, this fifth lumbar, is here, and when we get there, there's no motion. I want that thing moving, okay? The problem with chiropractic is it's too damn easy. It makes real smart people confused. It just does. Like I told you, the smartest people in our class are selling insurance now. So I'm going to come down to the fifth lumbar, okay? I'm going to come off, and this is a form of Merrick, which was the very first, they call it toggle kind of a form of that, but it's very specific. What I'll do is I'll pull tissue from the right side to the left, okay? And as I pull tissue, my piezoform is coming right down into where the facet is, okay? It's coming right down into that gap, right down into it. So I'm picturing my hand rolling over and right down here, because that's what I want to move. I want those two bones to separate, okay? So I'm coming right down in there. Now, in order to do this, two things are vital. Well, a lot of things. I'm going to deconstructing again. Tissue pull, hand placement, into joint play, and no BSing. You're not moving this unless you are ready to move this. Just plain and simple. Okay? So, and there it moves. Okay? Now, when I did that, again, I can't explain this. As I adjusted the fifth lumbar, I felt that the segment above, there's no pliability in there. So I'm going to come back in here, and I'm going to take that tissue pull up, and then I'm going to set the rest of it. But for teaching's sake, man, right through it. And you've got I come right around. Doctors, been in practice. Again, face down, fifth lumbar. Josh, sit up, face me. Hey, you did a great job today, and I'll see you tomorrow, okay? That's it. There's no conversations, no damn referral statement, blah, blah, blah. My referral statement was, I just moved your bone, you were